Good morning, everyone. Welcome to this very short presentation on addressing adolescent anemia in vulnerable Indian communities. It's a qualitative exploration that we undertook across vulnerable communities in the city of Mumbai. Literature review and objectives of the study are in front of you right now. Just to take you through very quickly, across all our National Family Health Survey data, we have seen that close to more than 50% of women and 25% to 29% of men in the age group of say 15 to 19 or 15 to 24 years are anemic in this country. The latest data set that we have is from the Comprehensive National Nutritional Survey, which says that the percentage of anemia has come down among both men and women in the same age range. However, we still find 40% girls and 18% boys in the age group of 10 to 19 to be anemic. Anemia among adolescents in urban slums is further compounded by issues of lack of toilet facilities within the housing, poor sanitary conditions, leading to war manifestations and other illnesses. Now, in keeping with this context, the objectives of the study was to capture experiences of adolescents and their parents participating in a community-based anemia management intervention and documenting the nuances of transformations triggered by these interventions. How did the program intervention work? The program intervention worked at three levels: the individual level, where we resorted to anemia testing, treatment, and follow-up; at the family or community level, where we worked through group education sessions with both adolescents and parents, home visits to track and counsel on treatment compliance, community campaigns on anemia management led by young people, sessions with teachers, adolescents, and neighborhood schools. At the level of the system, we resorted to co-designing and reviewing treatment protocols with medical colleges, where we have also been making referrals for severely anemic adolescents. In keeping with the demand, we have seen how adolescent participation has led to a higher demand. Lastly, capacity building of public health workers and quarterly interface have helped immensely. Looking at our quantitative data, we see that all these strategies have actually led to a prominent reduction in anemia. If you look at our data sets from 2019 and 20, we see that in a data set of 889 adolescents at pre-test, 51% were non-anemic, which increased to 74% who were found to be non-anemic during the post-tests. Situating the study, if you see, the study is situated within the critical theory paradigm. In terms of sampling, we resorted to purposive sampling. We considered representation across age, sex, and program sites for adolescents, parents, and other stakeholders. In terms of methods, we largely employed focus group discussions and in-depth interviews, along with content analysis of 214 drawings of a nutritious food plate by adolescent participants. We also engaged in interviews with clinical and non-clinical staff from public health posts, which are situated at the primary level of the public healthcare system, along with periodic informal conversations with field staff. If you look at the geographies, the study was situated across Dharavi and Kandivali in Mumbai and Kalwa in the Thane districts. What emerged from the study? The analysis of the study took place in terms of manual coding of the themes that emerged from the transcriptions of the focus group discussions as well as the in-depth interviews. These codings were further clubbed, or we formed buckets of the themes that emerged. We looked at patterns, and then we came to our key findings. We realized that some of the key findings of the study are that lack of awareness about nutrition prior to attending the sessions did go down, and we saw reduction in junk food consumption after the group sessions were conducted. We also saw that a wider access to junk food with no market regulations leads to temptation and negative peer influence when it comes to junk food consumption, and aggravates anemia. We find very interestingly that adolescent agency leads to an enabling environment. Gendered barriers in nutrition. We looked at, it was very interesting for us to see how boys received preference with food and also got more pocket money for fast food. Parental support is a must. Anemia management is a family affair. Non-compliance to treatment was a major barrier. Involvement of all levels of the public healthcare system is crucial to managing adolescent anemia effectively. These are some snippets from refreshers informed by our study where we employed something called the Poshan Ka Khel. Learning and policy implications, the major learning for us is that while we work on gendered notions of nutrition, we also need to involve young people in anemia management to a large extent. Anemia is not considered an illness in the common parlance unless severity leads to hospitalization. In terms of policy implications, while there are many, two really stand out. We need to formulate a policy-level national indicator on reduction in adolescent anemia to impact maternal health outcomes. We need to co-design protocols for a minimum package in implementation of RKSK, the Rashtriya Kishore Swasthya Karyakram. If you look at the Rashtriya Kishore Swasthya Karyakram, we have a budget of around 60 lakhs allocated for each district, especially for anemia management. This itself will go a very long way, especially if we employ convergence between health, the women and child development departments, and the education departments through the schools. Thank you very much. We hope we can pick up from these learning and see how we can scale a pilot like this for further implications. Thank you.